Hello, assalamu alaikum. Hope you are all okay. Today, I will discuss the role of transvaginal ultrasound in infertility. As a gynecologist, actually, I do believe that every gynecologist must know ultrasound because it is the clinician who knows ultrasound can correlate everything perfectly. So the gynecologist, if do the transvaginal ultrasound, she or he can diagnose the problem in a better way, and thereby he or she can manage the problem perfectly. So you can optimize your success rate like that. So I will discuss today the transvaginal ultrasound in infertility. Hope you all will like it, and it will be very helpful for the practicing gynecologist. So let's start my presentation. So today I'm going to sorry. I'll show you. Just wait a minute. Sorry. Okay. Now let's start my presentation. It's Dr. Anamul Haque presenting today's transvaginal sonography in infertility. As you all know, the ultrasound is an effective, easy to use, safe, and readily available non-invasive means to evaluate fertility potential. Most useful tools available to assess the causes of infertility and to implement many of the treatment used to ameliorate infertility. So in an infertility practice, you can diagnose the causes of infertility, like you can diagnose the pathology of the vaginal and cervical factor. Like here you see this is the uterus in a sagittal section. You are seeing multiple anechoic structure within the cervix. This is the Nabatean follicle. As you know, the Nabatean follicle form with the chronic cervicitis, and chronic cervicitis ultimately is also cause of infertility. That can you easily identify with the transvaginal sonography. And here, this is the normal anatomy of the uterus in a transvaginal scan. This is the sagittal section. In a sagittal section, here you see from here you see this is the body of the uterus. Here you see this is the uterus, and this is the internal os. Here see, and from that part this is the cervix. You see, this is the cervix, and this is the cervical canal, and this is the internal os, and this is the external os. So if you in a sagittal scan in a cervix you see like that, and this is the body of the uterus. Here you see the endometrium. This is the endometrium. This is the endometrium. So this is the endometrium, and this is the endometrial cavity. So this is in the this is in the proliferative phase. So you are seeing the three line 1, line 2, line 3, three echogenic line. So this is the endometrium. This is the in a sagittal section. And in a secretory phase, you will see the endometrium look like that. This is the echogenic. Echogenic means this is more white than endometrium, so this is echogenic. So there is no triple line, and endometrium is here echogenic, that is white. So this is the proliferative endometrium. So in a menstrual cycle, if you scan in a different phase, you will see the uterus and endometrium in a different lookings. Like in a menstrual phase, you will see the hypoechoic area, that is blood, and myometrial contraction are frequent, and endometrial thickness is less than 4 millimeter in a shedding phase, in a menstrual phase. But in early follicular phase, the triple line appears, and the endometrium thickness is 7 to 9 millimeter. But in late follicular phase, the endometrium thickness is like 9 to 12 millimeter at before just ovulation. And in the luteal phase, that is the secretory phase, the bright echogenic, fluffy appearance, absence of triple line, and thickness 10 to 14 millimeter. This is the normal anatomy of the endometrium in a transvaginal scan. Here, how you have to measure the endometrial thickness. This is very important. In endometrial, this is the sagittal section of the uterus, and you have to measure the endometrium, the widest part, from outer to outer. This is the endometrial thickness. And this is the 3D view of the uterus. In a three-dimensional view, endometrium look like that. This is the endometrium, you see, and this is the endometrial cavity. So here you see, this is the endometrium. This is the corneal part of the tube, isthmic part, the corneal part of the tube, and this is the endometrial cavity. And here you see, this is the external os of the cervix, and this is the internal os of the cervix. So, and this is the myometrium, and this is the fundus. So the clarity of the picture, you see the actual look like uterus in a 3D view. This is the typical 3D view of the uterus. And here you see the endometrium is more bright, echogenic, and very thick. So this is the typical picture of endometrial hyperplasia. So this is in a 3D view. This is the 3D view. And now let's see, in a infertility practice, congenital and acquired uterine anomaly is common. So as you know, the American Society of Reproductive Medicine classify uterine anomaly in 7 types. The class 1, type 1 or class 1, as you know, the only class 1, you know, both the Mullerian duct is absent or hypoplastic. So this is the absent uterus. In absent, when a female present with the absent uterus, as you know, the common symptom is the primary amenorrhea. And as most of the patient is unmarried, so you have to do the transabdominal scan. This is the abdominal scan with the full bladder. This is the bladder, you see. This is the urinary bladder, and this is the urine. So what we will find in a transvaginal, in a abdominal scan? Here, you will see in a full bladder, you will see the dimple. Here is the convex base with no dimple. This is the bladder base is convex and no dimple behind. So there is no uterine-like structure behind that. There is no uterine structure here. Uterus most likely will be here, but there is no uterine structure here. So this is the absent uterus. This is type 1. And here you see, this is the transvaginal scan. In the transvaginal scan, here you see the uterus. There is a uterus, small uterus, look like banana, not actually look like the pear shape. This is the banana shape uterus. And here you see, this is the internal os. This is this body of and this is the cervix. Cervix and body look like the same in diameter, and size also the same. So this is the infantile actually uterus or hypoplastic uterus this is. And now see the type 2. Type 2, as you know, the one Mullerian duct is present. So what happened, here you see the in a sagittal section, this is look like the normal uterine anatomy. In a sagittal section, you cannot differentiate that this is a normal uterus or a unicornate uterus. You see the endometrium is normal, but you will find that when uterus is inclined to one side of the pelvis, you must have the suspicion that there may be unicornate uterus. Then you have to do a transverse section view. In a transverse section view, when your probe moving towards the fundus, you will see that your endometrium is look like this. This is the big side. When you find the endometrium is the look like the beak of the bird, this is suggestive of unicornate uterus. And if you do 3D in a secretory phase, if you do the 3D ultrasound transvaginal scan, then you will see the endometrium, the typical banana sign. You see, this is the banana. So this is the suggestive of unicornate uterus. And type 3, as you know, both the Mullerian duct persist. So the patient has two cervix, two uterine body. So in a transvaginal scan, you will find two well-developed uterine body. So there should be suspicion of this is the didelphys or bicondate uterus. But in didelphys cases, you cannot confirmly say in a transvaginal scan this is the uterine didelphys. You have to correlate more clinically. You have to do vaginal examination. So in a vaginal examination, if you get two cervix, and in transvaginal scan you find two well-developed body. So, and if you get even you can get two vagina also. So this is the diagnosis that this is uterine didelphys. And now type 4. Type 4 is the actually fusion anomaly. The fusion anomaly means you have incomplete fusion of the two Mullerian duct. The most common thing is bicornate uterus. The bicornate uterus, if you scan in the secretory phase, you will see the two endometrial cavity. When you get two endometrial cavity, then you have to do the 3D transvaginal scan. If you do 3D transvaginal scan, then what happens? You will see the endometrium look like leaf. Endometrium is leaf-like. Both the endometrium is leaf-like, and you will see the dimple here. The dimple here is less than 5 millimeter, and you see the medial margin. This is the medial margin. Medial margin of the endometrium is convex, and if you measure the angle is this is the angle. This angle and this angle is more than 90 degree. So the endometrium if look like leaf shape, the medial margin is convex, and the dimple less than 5 millimeter, and the angle between the two endometrium is more than 90 degree. This is suggestive of bicornate uterus. And the type 4, type 5. Type 5 is the septic uterus. Here you see the no or minimal indentation on the fundus, and at least 5 millimeter uterine must have present. And you see here the endometrium, medial margin of the endometrium is straight. Here you see this is the medial margin of the endometrium is straight, and the angle, this angle between this margin is less than 90 degree. So this is suggestive of septic uterus. And the distance, most important thing, distance. If you draw a imaginary line at the top of the endometrial cavity. Then from this distance to the extension of the septum here must be more than 10 millimeter. So this is the septate uterus. And as you know, septate uterus two types: partial septate uterus and the complete septate uterus. So in a partial septate, when you see the septum when covers the endometrial cavity less than 1/3, this is called partial septate uterus. And if it is more than 2/3 occupy the uterine cavity, this is complete uterine septum. So now the type 6 is the arcuate uterus. In a 3D view, what you see? You see the endometrial cavities look like that. There is a fundal bulging. That the fundal bulging distance from the top of the endometrium to the bulge, this is less than 10 millimeter. In a septate uterus, it is more than 10 millimeter. So this is septate. But if it is less than 10 millimeter, it is arcuate uterus. And in a septate uterus, find what is the angle is less than 90 degree. In arcuate uterus, angle is more than 90 degree. This is the difference from septate and arcuate uterus. Now we see here the difference between arcuate and septate uterus. You see, in a arcuate uterus, the distance, what I'm saying, from the top to the bulge, this is distance is less than 10 millimeter. If the distance is more than 10 millimeter, this is septate uterus. And if distance less than 10 millimeter, that is arcuate uterus. And the last class 7 or type 7 is the, as you know, the T-shaped uterus. When there is very rare form of endometrial abnormalities, most related to diethylstilbestrol drugs anomaly. And this is the endometrium, typical T-shaped endometrium. You see, this is the typical T. This endometrium, this is T-shaped uterus. So the just recapitulate. This is here. See, the endometrium is the leaf shape. Medial margin is convex. And the bulging less than 5 millimeter. The angle more than 90 degree. This is bicornuate. This is also bicornuate 3D view. And here you see the distance from here to here is less than 10 millimeter. An angle more than 90 degrees. So this is arcuate. And here distance from top to the bulge is more than 10 millimeter. From here to here. And angle, this angle and angle is less than 90 degrees. So this is the septate uterus. And this one is the arcuate uterus. And the endometrium is leaf shape. So this is the bicornuate uterus. This is the difference of the bicornuate, arcuate, and septate uterus. So that already I discussed what is the characteristics difference of the bicornuate, septate, and arcuate uterus. So now let's the evolution of the uterine cavity and the oviduct in infertility. As you know, previously we commonly use to see the interior of the uterus and to see the patency of the fallopian tube. We commonly use hysterosalpingography. But in a modern era, in infertility practice, actually hysterosalpingography more or less obsolete procedure. Now we prefer the saline infusion sonography. That is called Scion test or saline infusion sonography. Somebody says hysterosalpingography or sonohysterography. When you use contrast media, that is called hysterocontrast sonography. Now let's see what is that. Here you see in a saline infusion sonography, what we do actually we insert a Follis catheter, pediatric Follis catheter, number 5 or 6 Follis catheter. Then we inserting the Follis catheter, then the balloon of the Follis catheter. This is the balloon of the fallopian catheter. We inflate the balloon with 1 ml normal saline. Then with the catheter, we introduce normal saline within the uterine cavity. As you know, the uterine cavity is the hollow viscous, So if we insert saline, then it will cause a distension of the uterus. So the interior of the endometrial cavity we can visualize in a better. So this is the normal endometrial cavity you see in the sagittal section. When you are inserting the fluid, the endometrial cavity distended, so you are clearly seeing the interior of the cavity. Here you see in a 2D scan, 2D transvaginal scan, you see this is the endometrium. This is the endometrium. What you are seeing, a echogenic structure within the endometrium. With this 2D view, it's very difficult to say this is the endometrial hyperplasia or thickened endometrium or endometrial polyp. But if you do saline infusion sonography and if you insert saline within the endometrial cavity, here you see the echogenic structure is hanging within the endometrial cavity. You see the hanging. So this is endometrial polyp. And if you do the Doppler ultrasound, then you will get the feeder vessel here. So this is confirmed that this is endometrial polyp, and the type, number, accurately you can assess through transvaginal saline infusion sonography. Here you see, this is the 3D view of saline infusion sonography. In a 3D view, you see the endometrial, this is the endometrial cavity. You see, this is the endometrial cavity. And you see the echogenic, this is the, when you are inserting the fluid, this is the fluid within the endometrial cavity. And you see this is the endometrial polyp arising from one of the uterine valve. And here is the feeding vessel. So this is the clear, confirm your diagnosis that this is endometrial polyp. So the saline infusion sonography is the very important tool that nowadays it minimizes the uses of hysteroscopy. Even the specificity and sensitivity is same like hysteroscopy. So this is actually the virtual hysteroscopy, the transvaginal sonography. And here you see the endometrial cavity. This is the endometrial cavity, and while you are inserting fluid, you see the separately you can identify the 3-4 polyp here. 1 polyp, 2 polyp, and 3rd polyp. So this is the magic of the saline infusion sonography. And here you see the 2 polyp here. That actually not possible without the saline infusion sonography. With the use of saline infusion sonography, you can diagnose very easily the number of and size of the polyp accurately. And here you see in a 2D view, in a transvaginal scan, you see the homogeneous echogenicity within the endometrium. There is no triple line. You cannot distinguish this is a thickened endometrium or uterine syncytia. What is this? You cannot say with the 2D image. But if you do saline infusion sonography, you see when you are inserting fluid, you see there is a multiple septum here. One septum and second septum is here. So this is uterine syncytia. That you can diagnose easily with the transvaginal saline infusion sonography. Previously, that is only possible with the hysteroscopy. So nowadays, the hysteroscopy and the saline infusion sonography, the specificity and sensitivity is same. So now let's see here. Here you see in a 2D view, in 2D saline infusion sonography, you are seeing that there is a intrauterine adhesion. But if you do 3D, you will see that the filling defect accurately look like that. This is the uterine syncytia. Here you also see the uterine syncytia. Here is the fluid within the endometrial cavity. This is the fluid. This is the fluid, and This one whole thing is endometrial, massive endometrial adhesion here. So this is endometrial adhesion. So accurately you can assess where the adhesion is, and thereby you can manage accordingly through hysteroscopy. So now when you are inserting more fluid, then fluid will go through the tube. So the interior of the tube you can visualize easily. Here you see the tube is the retort shaped tube. Here you see this is the retort shaped tube. So this is the typical picture of hydrosulfings, and this is the sign of chronic sulfingophoreitis in case of chronic PID. You see this is the retort shaped tube. So this is the hydrosulfings, and if you this is sagittal view, and if you see in a transverse view, you will see multiple septum cogwheel. This is called multiple cogwheel pattern septum. So this is multiple cogwheel septum. So this is the typical sign of hydrosulfings. And here you see there is the tube look like echogenic. You see, tube is more echogenic here. So this is the typical sign of pyosulfings. Here this is the tube. You see, and here you see the tube is look like chocolate cyst. Look like chocolate cyst. This is the look like chocolate material here, and this is the typical sign of hematosulfings actually. And now you are inserting more fluid within the uterus, so the fluid will comes through the fallopian tube to the peritoneal cavity. When you push more fluid, you will see the femoral end of the tube. This is the femora. Femoral end of the tube you will see floating within the peritoneal cavity. This is the peritoneal collection of fluid. So you are seeing the femoral end of the tube. So this is the indication. This is the a sign that your tube, fallopian tube, is patterned. If you put the colored Doppler, that is the power Doppler. If you put power Doppler, then you will see the chaotic color within the peritoneal cavity. That is suggestive that that fallopian tube is patterned. And now, if you search for the endomyometrial pathology, you see here there is a isoechoic structure within the myometrium, well-defined mass that is suggestive of actually fibroid uterus. But within this view, you cannot say this is arising from the anterior wall of the myometrium or posterior wall of the myometrium. But if you do saline infusion sonography, when you inserting the fluid within the endometrial cavity, you will see clearly whether it is arising from the anterior wall or posterior wall. That is why, for the management purpose, if you do myomectomy, it will be very convenient that you can assess where you have to put the incision, where you have to cut in the anterior wall or where you have to cut the posterior wall. This is very important in case of myomectomy. And here you see the 3D view of the myometrium in a saline infusion view. You see, in a saline infusion view, you can easily say this is the saline within the cavity and the fibroid completely within the endometrial cavity. So you can diagnose this type of fibroid actually impairing the fertility potential. So here you see there is a hypoechoic mass arising from the fundus of the uterus that pushing the endometrial cavity a little bit. Here you see there is a hypoechoic mass compressing the endometrial cavity from lateral side. Okay, and here you see the mass arising from one of the wall, but 90% of the mass protruding towards the cavity. So this type of, here you see this number 1 and number 2 fibroid actually causing infertility. But here you see this one, number 3 and 4, actually not the causes of infertility. But that's why this is very important In a saline infusion sonography, you can accurately assess the number, site, and the type of the fibroid, and accordingly you can manage. Here you see, accordingly, actually nowadays the type of the fibroid can be classified in a T0. T0 fibroid is the pedunculated, that is more than 90% actually protruding towards the cavity. That is the T0 or pedunculated fibroid. And type 1, when the more than 50% of the fibroid is protruding towards the cavity. This is type 1. When more than 50% of the fibroid pushing towards the uterine wall, this is called type 2. And type 3 basically is subserosal. So accordingly you have to manage. Here you see the T0 and T1 you have to manage hysteroscopically, and T2 and T3 you have to manage laparoscopic myometrium. So this is very important. That you can do, we can diagnose only by Hysterocontrast sonography, the saline infusion sonography, and with the 3D help. So here you see some abnormal fibroid. Here you see there is the echogenic structure that is like, this is the degenerated fibroid actually. So degenerated fibroid, this is the typical picture of degenerated fibroid with the mixed echogenic structure. And here you see the degenerated fibroids sometimes get calcified. So if you get echogenic structure within the fibroid, within the masses of the fibroid, this is called Um's calcification. And if you get the echogenicity within the false capsule of the fibroid, look like fetal head. So this is the axial calcification of the fibroid. And here you see in a sagittal section, you're seeing the ill-defined sunbeam appearance one structure. This is called sunbeam appearance. This is called sunbeam appearance. In a sunbeam appearance, you are seeing the ill-defined mass. Within the mass, you are seeing the multiple anechoic structure. This is suggestive of adenomyosis. Ill-defined mass with the sunbeam appearance with a multiple anechoic structure is suggestive of adenomyosis. But if you see, if you put color, if you do color Doppler in a fibroid, what will happen? There is a oil circumscribed mass, and if you put color Doppler, you will see vascularity around the periphery. So this is suggestive of fibroid uterus. But if you see the vascularity within the mass, this is suggestive of adenomyosis. So this is the difference of the fibroid and adenomyosis. So here, this is the difference. Sometimes degenerate fibroid, this is the mass. Actually, this is the degenerated fibroid. The degenerated fibroid in a color Doppler, you will get vascularity within the mass. Otherwise, you will get vascularity around the periphery. But if you get in a oil circumscribed mass, if you get vascularity within the mass, this is degenerated fibroid. This is not adenomyosis. This is degenerated fibroid. And now look the ovarian pathology. Here you see in a 2D view, this is the normal ovarian structure. Normal ovaries look like that. It has a cortex and medulla or stroma. In a cortex, the multiple anechoic structure arranges peripherally. This is the antral follicle. This is the antral follicle. So this is the normal. This is the normal ovarian structure. But in a polycystic ovarian syndrome, you will find multiple, more than 10 follicle arranges around the periphery, and they will appear in a necklace pattern that is suggestive of polycystic ovarian. This is the typical picture of chocolate cyst. You will see the ground glass appearance, homogeneous echogenicity, the ground glass appearance of this is the chocolate cyst, typical picture of chocolate cyst. Here one chocolate cyst, here you will see two chocolate cysts. And here you see the mixed echogenic structure look like chocolate cyst, but when you will get this type of picture, anechoic and echogenic structure, this is suggestive of corpus luteum cyst. And if you do color Doppler, you will find abundant vascularity within the mass. So this is the corpus luteum cyst. And in infertility practice, this is very important. You have to monitor your follicle. So in an IVF cycle, we usually do the day 2 scan, baseline scan. In a baseline scan, what you have to assess? You have to assess the size of the ovary, where there is any cyst or cyst present or not. And you have to assess exactly the number of antral follicle recruited in this current cycle. So in a baseline scale, these are the antral follicle, anechoic, small anechoic structure you are seeing. This is at the antral follicle in a day 2 scan. In a day 2, we have to assess the exactly number of the antral follicle. So accordingly, you can optimize your dose of stimulation, how much drug you need. You can assess with the baseline scan. And recently, there is a sonography software, as more advanced machine, that in a sonography machine, this is called 3D ultrasound virtual organ computer aided analysis, or vocal, or some machine called sonography. In a sonography, what it is the 3D view. In a 3D assessment, machine can automatically calculate exactly the number and size of the follicle, and in a different, showing in different color. That's the very helpful when in a IVF cycle, when you have more number of follicle, that is very difficult to count manually. So in a sonography software, by using sonography software, you can accurately calculate how many follicles actually recruited and the exact size of the follicle. And how you have to measure the follicular diameter. In a follicular diameter, you have to measure in a 2 diameter. The largest, you have to scan the follicle in a such a way that you have to make it more or less round. Then you have to measure the diameter in a 2 direction, from here to here. Then second one just exactly perpendicular to that line, or 90 degree. That the average diameter is the actually diameter of this follicle. So now this is very important, that you can predict the time of the ovulation. How you can predict? The potential signs of impending ovulation are the presence of a dominant follicle that is more than 16 to 18 millimeter size, and the presence of cumulus oophrus, where you are seeing that there is a cumulus oophrus. If you see that the ovulation is impending within 36 hours. That's very important for time coitus or IUI. And another thing, when you are seeing the anechoic area, the double contour around the follicle, then ovulation is impending within 24 hours. But if you see the separation and folding of the follicle lining, so ovulation will be within 6 to 10 hours. That's very important. 36 hours. If you see cumulus oophrus, if you see double contour, ovulation is impending within 24 hours. If you see separation and folding of the follicle lining, ovulation will occur within 6 to 10 hours. And irregular and creatinine margin of the follicle and thickened proliferative endometrium, all are the sign of prediction of ovulation. Now, you see, this is the follicle. In a 2D view, you are seeing this structure is cumulus oophrus. If you do 3D, then cumulus oophrus is look like that. If you see the cumulus oophrus, that is the sign that your ovulation is impending within 36 hours. And here you see the around the follicle, if you put the power Doppler, You see the power Doppler, if it shows more than 75% vascularity, this is the matured follicle. And if you measure the peak systolic velocity, if the peak systolic velocity is more than 10 centimeter per second, that is the matured follicle. Here you see different stages of follicle. If you do the color Doppler, that is power Doppler. If you do power Doppler, here you see the follicle is smaller size. Accordingly, if you see the color around the periphery is less, this is less color, then this is a little bit more color, and here is also more color. You see this follicle is bigger follicle. This is the matured follicle size around 18 to 20 millimeter, and in a power Doppler, the vascularity around the periphery is more than 90%. You see, if more than 70%, this is the matured follicle. So what is the sign that the follicle is matured? In a gonadotropin cycle, when the size of the follicle is more than 16 millimeter, this is the matured follicle. But in a clomiphene or letrozole cycle, if size more than 18 millimeter, this is the matured follicle. And if you get what I'm saying, the peripheral blood flow in a power Doppler more than 75%, this is matured follicle. And peak systolic velocity more than 10 centimeter per second. If you see cumulus suffrus, this is the matured follicle. These are the sign actually we will see whether this follicle is matured or not. And how we confirm the ovulation. If you see a follicle and 1 day later the disappearance of the follicle, so this is the confirm that the ovulation has occurred. And the decrease in follicular size, if you see fluid in the cul-de-sac, so this is also the sign of the ovulation. And development of intrafollicular echoes, that is the corpus luteum. If you see the corpus luteum, that is sure that the ovulation has occurred. So you are seeing the fluid in the pouch of Douglas, and you have seen the follicle clear anechoic structure now become a mixed echogenic structure. This is the corpus luteum. So if you see the fluid and if you see the corpus luteum, so ovulation is confirmed. And the most important thing, after ovulation, corpus luteum fall, and whether corpus luteum is producing adequate progesterone or not, you can assess by power Doppler. If you put power Doppler and if you see the vascularity around the corpus luteum is more than 75%, this is the sufficient corpus luteum or matured corpus luteum. This is very important in infertility practice. Here you see the vascularity around the corpus luteum more than 80%. So this is matured or adequate corpus luteum or sufficient corpus luteum. So accordingly, there is a uterine biophysical profile or called uterine scoring system for reproduction. It is called Applebaum's uterine scoring system for reproduction. Here are some parameters like you see endometrial thickness, endometrial layering, endometrial motion, myometrial echogenicity, urinary pulsatility index PI, endometrial blood flow and myometrial blood flow. These are the parameters. So if you get endometrial thickness like 10 to 14 millimeter, that is the more point, score is 3. Endometrial layering, if you 5 layering, this score is 3. If you get more than 3 endometrial motion, the score is 3. And myometrial echogenicity, relatively homogeneous, so score 2. If urinary PI less than 3 or less than 2, the score is 2. You see, less than 2. And endometrial blood flow in zone 3 or 4, this is score 2. And if myometrial blood flow abundant, then score 5. So these are the score. And here you see the endometrium. Here is the zone. We can differentiate it in zone up to 5. What is the zone 5? Zone 1 is the myometrium actually. This is the myometrium. This is the endometrial endometrium and endomyometrial junction. This is called zone 1. This is endometromyometrial junction is zone 2. This is zone 1. This is zone 2. And this endometrium to endometrial up to cavity, these from this side is a zone 3, and at the end my endometrial cavity junction, this is a zone 4, and within the cavity this is zone 5. So if you get vascularity up to the zone 4 and 5, this is the matured endometrium. So here this is the pre-ovulatory endometrium, and this is the after ovulation. This is secretory phase endometrium is here triple line absent, and echogenic endometrium. This is the secretory phase endometrium after ovulation. So accordingly, we can grade the endometrium. This is very important in case of infertility practice. Whether your endometrium is prepared for implantation or not, you can assess by grading, making grading. In a grade A endometrium is more echogenic than myometrium. That is, when you will get in the secretory phase, your endometrium must be echogenic. So this is the grade A endometrium. This is the perfect for embryo implantation. And when endometrium is hypoechoic to myometrium, this is grade B, and homogeneous hyperechoic, this is grade C. Here the endometrial the endometrial contraction you are seeing in the ultrasound, and here see uterine artery Doppler PI. In a uterine artery Doppler, here see in a Doppler, when you see the PI less than 2, this is more perfect for implantation, and if peak systolic velocity must be more than 10 centimeter per second. So that is the good for the endometrial implantation. The zone 1 that I said, the zone 1, zone 2, zone 3, and zone 4. Here you see zone 1, what I am saying, the zone 1 is the myometrium, zone 2 is endomyometrial junction, zone 3 is this one is the zone, this one is the zone 1, this is the zone 2, and this one zone 3, and within the cavity is the zone 5. Here you see the vascularity within zone 1, that is in the myometrium, not up to this is the endometrium. So this is the endometrium, vascularity within the myometrium only. This is the zone 1 vascularity, and zone 2, when vascularity extend up to the endometrium, this is zone 2. This is zone 2, and here endometrial up to the junction, endometrial cavity junction extends the vascularity. So this is the zone 3 vascularity. When the vascularity within the endometrial cavity, this is zone 4. When this zone 3 and zone 4 is perfect for implantation, especially zone 4. So this type of endometrium you needed for implantation. So what is the matured endometrium? The matured endometrium we see when the thickness 7 to 10 millimeter. This is the grade A endometrium, and vascularity zone 3 and 4. These 3 is very important in infertility practice management. And you can also see uterine artery PI. This is important for the embryo transfer in case of IVF. If you get this is less than, must be less than 3. It is better if it is less than 2. If it is less than 2, then you can transfer your embryo. This is very important in the IVF technology. So in a uterine scoring system for reproduction, the perfect score of 20 has been associated with conception rate is 100%. If you have score is 20, so your chance of pregnancy is 100%. But score 17 to 19, the conception chance is 80%. Score 14 to 16, the chance of pregnancy is 60%. If score less than 13, sorry, there is no chance of pregnancy. So with this scoring system, you can actually optimize your success rate. For as a clinician, as an infertility specialist, you must know this scoring system. Now, the therapeutic uses of ultrasonography in infertility. Here, as you know, nowadays in a modern era, we are 100% using transvaginal ultrasound for oocyte retrieval. Previously, it was done by laparoscopically. Now, 100% cases we are doing the transvaginal ultrasound for oocyte retrieval. For oocyte retrieval, there is a software that's the needle biopsy guide. Here you see the arrow. This is the needle biopsy guide. The basic thing, you have to focus your oocyte within this arrow. Then you have to insert your oocyte retrieval needle. This is very simple, actually, simple software. And nowadays, we are using also for the simple cyst, we are aspirating with the transvaginal ultrasound. You can aspirate also hydrosulfings. And even nowadays, in endometriosis cases, when you have chocolate cyst, it is better nowadays for most of the infertility specialists are advising the aspiration of the endometriotic cyst rather than doing unnecessary surgery. Because if you do unnecessary surgery, then you are actually compromising your follicular count. Your MS will be low, then follicular reserve will be low. So if you do endometrial aspiration and thereby you are give generis analog 2 or 3 cycle, then you give stimulation. That is better for the patient rather doing the surgery. So nowadays we are doing also ultrasound guided embryo transfer. This is basically with a moderately full bladder. In abdominal scan, you are seeing the uterus. This is the uterus and endometrial cavity is seeing. So with the ultrasound guide, we are transferring the embryo within the cavity. So this we put the air bubble within the catheter, so in front and behind the embryo. So the air bubble can be seen in echogenic structure. That is the reassuring that you have transferred the embryo. And this picture also we are showing to the patient. The patient also reassured that her embryo is transferred. This is very reassuring nowadays, actually. And also, if you do ultrasound guided transfer, your success rate will be optimized, actually. Now, in a infertility practice or ART, the ectopic pregnancy is more. So you have to confirm that this is intrauterine pregnancy. Here you see in a sagittal section, the uterus here. This is the uterus, and you see there is a double decidual ring. This is the one ring and another ring, double decidual ring, and the fetal pole you are seeing. So this is the reassuring that this is intrauterine pregnancy. But unfortunately, you can find that this is the uterus in a transverse section. The uterine cavity is empty, but you are seeing the double decidual ring along the side of the uterus, and even you are seeing the fetal pole. This is suggestive of ectopic pregnancy. And if you put the power Doppler, you see there is a fire ring around the around the sac. This is very suggestive that this is ectopic pregnancy. Here we see the mixed. There's a complex mass with the free fluid within the peritoneal cavity, and this is suggestive of rupture ectopic. And if you put color, this is multiple chaotic pictures. This is suggestive of rupture ectopic pregnancy. And sometimes, very unfortunately, you can find that there is a sac within the uterine cavity, and there also another sac outside the cavity. So this is the heterotrophic pregnancy. You can sometimes get the heterotrophic pregnancy. And here you see there is a gestational sac-like structure within the ovary. This is ovarian pregnancy, and you will get free fluid in the cavity. This is a rupture ectopic pregnancy. And now in a ART cycle, multiple pregnancy is common because we are transferring 2 or 3 embryo. So there is a more chance that the multiple, even 3 pregnancy, even 4 embryo can be transferred. So you can get 4 pregnancy also. So in a reproductive management, we are now doing the selective fetal reduction or selective embryo reduction or multifetal pregnancy reduction. So in a multifetal pregnancy reduction cases, if we can reduce the pregnancy up to 2 by doing transvaginal ultrasound. In a transvaginal ultrasound, we can reduce the pregnancy even up before 8 weeks, 7 to 8 weeks, you can reduce the pregnancy. But if you do abdominally, conventionally, we are doing the fetal reduction at 12 weeks or 13 weeks of gestation. So this is the higher order multiple pregnancy that you have to reduce to up to 2. And in a modern era, in a fetal medicine, so this is now the common practice that at 11 to 14 weeks, we are doing the genetic screening of the fetus. So this is very important that we can screen the fetus at 11 to 14 weeks with transvaginal ultrasound. Because as you know, the transvaginal ultrasound frequency is more. This is 7.7 to 9 hertz. But in abdominal scan, this is the resolution is low. So if you see in the transvaginal scan, you will see better the fetal structure. You will see the nasal bone. You can assess the nuchal translucency. You can also assess the ductus venosus flow and the tricuspid regurgitation. As you know, the 4 marker nasal bone, anti-scan, anti, and the TR and DV, ductus venosus and tricuspid, these 4 marker actually we assess for the Down syndrome screening or trisomy 13 and 18 and 21 marker. That you can assess with the transvaginal ultrasound is better way. And lastly, we in an infertility practice, we occasionally face the deadly complication, the ovarian hyperstimulation syndrome. That ovarian hyperstimulation we can manage by aspiration of the fluid, and even we can aspirate the peritoneal fluid also through transvaginal ultrasound. For the management of the ovarian hyperstimulation syndrome, we use transvaginal ultrasound. So in a conclusion, I may conclude actually the transvaginal sonography is a modality of choice for assessment of female genital tract and management of infertile female. Doppler further increases its value as it assesses vascular changes which are representative of hormonal changes occurring throughout the menstrual cycle. Interventional ultrasound is becoming more and more in use. Advancement in technology will extend its use in different application. And thank you. So that's I actually conclude my presentation. I think there is okay. Is there any question actually who are seeing my program? I don't know. Okay. So this is my presentation. I think they are welcome there, sir. Is there any question? You can ask me. I can answer the question also. If there are any question. So if no question, then I can conclude my presentation. Thank you everybody for watching my presentation, and I think it will be helpful for you. And if it is better for you, then actually I will be inspired to present more in future. Thank you everybody for seeing my presentation. Thank you.